routinely do all this, so if they say examine the abdomen of this patient and you were not told whether the patient is jaundice, patient is having gastric outlet obstruction, patient is having difficulty passing urine, will you be doing all these ones I did? No. You just do the routine. Is that clear? If you do all those ones, you won't get extra mark. You may waste your time, they will ring the bell, you lose mark. Is that clear? So after palpation, you go to percussion. In the abdomen, you should note this. Percussion is done to assess for ascites. Percussion is done to assess for what? Ascites. We don't like we do in the chest. You know how we do in the chest? You percuss every region. Is it not so? We don't do like that in the abdomen. You don't come and be percussing each region. You don't do like that. Our percussion in the abdomen is to assess for ascites. So how do you do it? First of all, on your inspection, the abdomen must not have been distended. Because if the abdomen is distended, it means the ascites is massive. In such cases, we don't use percussion to locate the ascites. We use what we call fluid thread. Is it clear? Demonstrate how that is done. So, but if the abdomen is not distended, you must percuss to assess for ascites. How is it done? You face the patient, you locate either just above the umbilicus or just below the umbilicus. You place your hand at the midline. You focus on the middle finger and you focus on the middle phalange of the middle finger, and you will use the middle finger of your right hand to strike as the hammer. Are you following? Are you following? If you choose to use your index finger versus index finger, you will not score any mark because that is not the method. Is it clear? So you come, you place your hand, you start from the midline, you percuss toward the side. You listen as you percuss for dullness. If you don't find any dullness as you percuss this side, you come back to the midline, you percuss to this other side. If you still don't find any dullness, you conclude there is no ascites. But if while you were doing this, you observe there was a dullness here, you leave your fingers there, you ask the patient to turn toward you. Turn toward me. Turn toward me. Then you still leave your fingers there, you wait for the fluid to settle. Then after that, you start to percuss again. What was dull before will become resonant or tympanitic, as we say in the abdomen. Then you now go along that line to the midline. When you get to the midline, it becomes dull. That is what we call shifting dullness. And once you find that on one side, you don't need to check the other side. You conclude the patient has what? Ascites. Is that clear? After percussion, you auscultate. In the abdomen, auscultation is meant to check for bowel sound. In the medical exam, they will tell you things like checking for renal blue and so on. We don't do it in the surgical exam. Our only emphasis for auscultation is bowel sound. But when you want to check for the bowel sound, you will not do it like a native doctor. You know how a native doctor does his own. You will just try the stethoscope in the way. If you do like that, you will not get the mark. You must first of all show to the examiner where you are putting your stethoscope. Is that clear? So you will come, you locate the umbilicus with one finger, then you run your finger along the iliac crest to locate the anterior superior iliac spine. Then in between the two, 1/3 of the way from the anterior superior iliac spine, or 2/3 of the way from the umbilicus. That is where you now put your stethoscope and then you listen. Is it clear? So you must locate it before you put it. In the marking scheme, there are marks for doing that. If you don't do it, you lose those marks. Is it clear? Then after that, you are done with the anterior abdominal wall. The other aspect of routine abdominal examination is rectal examination. You must not forget. At that point, you now tell the patient to turn and take the left lateral position, bending the knees, flexing both knees. Most examiners will stop you and say don't bother, but they will give you the mark. Is it clear? Or you turn and face the examiner and say, sir, I want to do a rectal examination. They will tell you don't bother, but he will give you the mark. But if you just forget, you didn't make any attempt, they will not score you any mark for rectal examination. They may even give you minus for not doing it. So that's why you must be thorough and very thorough. Is it clear? In routine abdominal examination, we don't examine the urethra. But if a patient has, you suspect a patient has stricture, he has difficulty passing urine, or he has a hernia, you must examine the urethra. Is it clear? It's abdominal